Hello, welcome to all of you. I'm Dr. Vinita Tekchandani, and today we'll be discussing a topic that is extremely relevant to our country, and that is carcinoma of the tongue. The reason why it is relevant is because India holds the dubious distinction of having one of the highest rates of CA tongue in the world. Conducting today's lecture is Dr. Akshay Mishra, a renowned maxillofacial surgeon. A very good day to you, sir.
Good afternoon, Vinita. She is absolutely right when she says that this is an extremely relevant topic. It is indeed a very sad state of affairs that India has such a high incidence of CA tongue. The single most important reason for this is the rampant use of tobacco. Tobacco in any form, be it cigarettes, BDs, chewing tobacco, gutka or mishri, is highly carcinogenic and is the main etiological factor for CA tongue. It is the severe lack of awareness that is the primary reason for the widespread use in our country. Another thing that is important to remember here is that 90% of oral cancers are squamous cell carcinomas. And because the tongue has a rich lymphatic drainage, which is the primary route of spread of squamous cell carcinomas. Metastases in these types of cancers are also quite common. So like us Indians, the commonest cancer of the country also likes to travel.
Thank you so much for this introduction, Doctor. Now let us move on to the learning objectives of today's lecture. Today we will be studying the anatomy of the tongue, epidemiology of CA tongue, its etiology, some pre-malignant conditions, clinical features of CA tongue, along with its examination. We will also be studying some investigations, staging, treatment, prognosis, and prevention of CA tongue. Sir, could we start with the anatomy of the tongue?
Sure. I'm sure all of you remember the anatomy of the tongue quite well. So we will cover this topic very briefly. We will be using this 3D model to study the anatomy. Isn't it wonderful? Perhaps soon we will be able to do virtual operations too. This here is the dorsal aspect of the tongue. The anterior 2/3 of the oral part of the tongue is divided from the posterior 1/3 or the pharyngeal part of the tongue by the terminal sulcus, which starts in the midline from the depression called as the foramen cecum. The terminal sulcus or sulcus terminalis runs laterally and anteriorly from the foramen cecum in the shape of a V. The median sulcus, on the other hand, runs straight down towards the tip of the tongue and separates the left and the right sides of the tongue. The entire surface of the tongue is covered by stratified squamous epithelium and the lingual papillae. There are 4 different types of papillae in the tongue. They are the filiform, fungiform, foliate and circumvallate papillae. The most numerous are the filiform papillae. They cover most of the dorsal surface or the anterior 2/3 of the tongue and have numerous keratinized epithelial projections. The least numerous are the circumvallate papillae. These are 8 to 10 and these dome-shaped structures and they are situated just proximal to the terminal sulcus. They are the largest of the papillae and you can even palpate them. People in the habit of chewing their tongue at times actually feel them and not expecting to feel anything bumpy or what we all think is rough but reasonably even surface actually mistake them for a pathology thinking they have cancer. But in the context of today's topic, I would much rather prefer to have a patient come to me mistakenly thinking that he or she has cancer rather than someone who actually does have a pathology but fails to bring it to the notice of the medical practitioner. There are 2 other more types of papillae on the tongue. They are the fungiform papillae, which are present on the tip, the dorsal and the lateral sides of the tongue, and the foliate papillae, which are situated on the sides and the back side of the tongue. What is significant here is that there are hardly any filiform papillae on the lateral sides of the tongue. And since they have only ones that are keratinized, the sides of the tongue is most vulnerable to risk factors that can lead to malignancy. In fact, the maximum occurrence of CA tongue is on the lateral aspect of the tongue. Now let's look at the muscles, lymphatics, innervation and blood supply of the tongue. The muscles of the tongue are divided into 2 groups, extrinsic and intrinsic. The extrinsic muscles have their origin from bone but are inserted within the tongue, while the intrinsic muscles have both their origin and insertion within the tongue. Let us look at the extrinsic muscles first. You can see the genioglossus, the hyoglossus, the styloglossus, and the palatoglossus muscles. They allow for protrusion, retraction, and side-to-side movement of the tongue. The intrinsic muscles only change the shape of the tongue, namely lengthening, shortening, curling, flattening, and rounding. They are the superior longitudinal, inferior longitudinal, vertical, and transverse muscles. Tell me something, Vinita. When you learnt about the muscles in anatomy, did you wonder how muscles that are not inserted on the bone are able to affect movement?
Yes, sir, I did.
I'll tell you how. The tongue is what is called as a muscular hydrostat. So, it uses the principle of water being effectively incompressible at physiologic pressures. Using this principle, the muscles in the tongue work in cohesion. When one set contracts, it pushes the water in one particular direction. At the same time, another group of muscles relaxes, allowing the water molecule spaces, thereby altering the shape of the tongue. I always marvel at the design of the human body. So, let's move on to the next anatomical feature of the tongue, and that is the lymphatic drainage. As I mentioned earlier, the tongue has a rich lymphatic supply, and it propels the lymphatic fluid every time the tongue moves, which is when we open the mouth, talk, eat, drink, or swallow. And since lymphatics are the primary channel for carcinomas to spread, and since 90% of oral cancers are squamous cell carcinomas, the neck nodes are very commonly involved in CA tongue. The lymph vessels of the tongue drain into 4 nodes. They are the submental, the jugulo-omohyoid, the jugulo-digastric, and the submandibular nodes. All of these, in turn, drain into the deep cervical nodes.
Sir, I did not quite understand this. Could you please repeat it?
Sure. There are 4 main lymph nodes in the neck that the tongue drains into. They are the submental, the jugulo-omohyoid, the jugulo-digastric, and the submandibular. Now, let's look at another diagram. Here you can see that the lymphatics from the central area of the tongue cross over to the nodes from the other side as well. So, cancers in the midline can metastasize to lymph nodes on the other side. But the lymphatics from the lateral aspect of the tongue usually drain into the nodes on the same side. Is it clear now?
Yes, sir.
Okay. So, let's move on to the innervation aspect. The motor supply of the muscles of the tongue is via the hypoglossal nerve, except one muscle, that is the palatoglossus, which is supplied by the vagus. The sensory innervation of the anterior 2/3 of the tongue is via the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve and makes up the general sensory pathway. The other nerve, which is the chorda tympani nerve, a branch of the facial nerve, transmits the taste sensations. The lingual nerve has a unique clinical significance, which we will discuss later when we come to the signs and symptoms of CA tongue. Both taste and sensation of the posterior 1/3 of the tongue is given by the glossopharyngeal nerve. The last topic we need to know about the anatomy of the tongue is the blood supply. The primary blood supply to the tongue or to the anterior part of the tongue is via the lingual artery, while the dorsalis linguae supplies the posterior part. The venous return is via the lingual vein.
Thank you, sir. Could you please tell us about the epidemiology of CA tongue?
Sure. As you rightly said earlier, CA tongue is the commonest form of cancer in the country. As far as the distribution of cancer on the tongue goes, the majority occur in the middle third. Roughly 25% occur on the posterior third and 20% on the anterior third. 96% of the times it occurs on the lateral side of the tongue and 4% on the dorsum. Like I mentioned earlier, because the lateral aspect of the tongue has hardly any filiform papillae on the lateral aspect of the tongue, making it more vulnerable to cancer. Oral cancers constitute 30% of all cancers, and all of them, about 10% are tongue cancers. So the incidence is very high, and unfortunately it is on the rise. Coming to the subject of young adults, CA tongue is presenting feature at a young age also. However, this partly could be due to the earlier detection rates. But tobacco use is also being observed in this lower age group, which is a worrisome sign. If you compare between men and women, it seems that this is more of a disease of a men, but this is to do with increased tobacco consumption among males. Female hormones, however, have not demonstrated any protection against it. As far as the socio-economic classification is concerned, it is more prevalent in the lower strata of the society. Overall, it is quite a bleak scenario, and as I mentioned earlier, the perils of tobacco use need to be strongly imposed upon our society.
That's very true, sir.
Now, moving on to the etiology, the causative factors of CA tongue can be conveniently remembered as we call it as the 6 S's. These are smoking and all other forms of tobacco, spirits, sharp teeth, syphilis, sepsis, and spices. Of late, research has shown that the human papilloma virus is one of the most significant etiological factors. Who doesn't know Michael Douglas, the famous Hollywood star, and also a CA tongue survivor, has made HPV quite famous. So apart from the 6 S's, HPV should be easy for you to remember. The primary mechanism of all these etiological factors is a persistent irritation of the squamous epithelium. Spirits, that is alcohol, also have an additional mechanism of action. They help to dissolve the carcinogens from cigarette smoke, and these have the sustained effect on the mucosa. Now let's move on to some pre-malignant conditions. Here, it is important to understand that pre-malignant conditions do not always result in malignancy, but the likelihood of them turning in cancerous are very high. So they need to be treated effectively and efficiently. I will enumerate some of them, and then we will discuss each one of them in detail. They are as follows: leukoplakia, erythroplakia, chronic hyperplastic candidiasis, oral submucous fibrosis, and syphilic glossitis. The other ones are silderopenic dysphagia, oral lichen planus, discoid lupus erythematosus, and disc keratitis congenita. Leukoplakia is a whitish grey patch on the tongue. It is usually seen on the ventral or the lateral surface of the tongue and is caused by a chronic irritation of the mucosa, which is due to smoking, sharp teeth, or any other irritant. Initially, it was thought that 20% of all cases of leukoplakia develop carcinoma, but newer studies indicate that the percentage is fortunately lower. Erythroplakia is similar to leukoplakia, but except that it is erythematous or reddish. Alcohol and tobacco use have been cited as the risk factors. Sometimes a lesion contains both red as well as white lesions and is referred to as a speckled leukoplakia or erythroleukoplakia. Chronic hyperplastic candidiasis is a variant of oral candidiasis that presents as a whitish patch on the commissures of the oral mucosa. The major etiologic agent is candida, although other systemic cofactors such as vitamin deficiency and generalized immune suppression may play a contributory role as well. If untreated, a minor proportion may demonstrate dysplasia and develop into carcinoma. As the name suggests, oral submucous fibrosis is the fibrosis of submucous tissues. The single most important causative agent as we know it is the chewing of areca nut, or what we refer to as supari in common language. It is characterized by a narrowing of the tongue and hampered mobility and difficulty in opening the mouth. This causes a deterioration of the oral hygiene and nutrition, which further worsens the condition. Syphilis is now routinely rare, but the tertiary stage can cause diffuse glossitis as well, and atrophy of the lingual papillae termed as syphilic glossitis can be seen.
Yes, sir.
Hydrophilic dysphagia, also called as a Plummer-Vinson syndrome or the Patterson-Brown and Kelly syndrome, is characterized by iron deficiency anemia, glossitis, ileosis, esophageal webs, and difficulty in swallowing. Although rare, it is relevant due to increased risk of squamous cell carcinomas. Oral lichen planus is an autoimmune disorder which presents as lesions that resemble lichen, and hence the name. Although symptoms can usually be managed, patients require regular monitoring because they may be at risk of developing malignancy in the affected areas. The last two pre-malignant conditions are the discoid lupus erythematosus and the disc keratosis congenita. I know that these are a bit difficult to remember, but you must understand that if you come across such a condition in clinical practice and successfully treat it, you have averted a potentially cancerous lesion. So make sure you remember these well. Let us look at the table once again. We have leukoplakia, then erythroplakia, chronic hyperplastic candidiasis, oral submucous fibrosis, syphilitic glossitis. And again, sideropenic dysphagia, oral lichen planus, discoid lupus erythematosus, and disc keratosis congenita. Of these, leukoplakia, erythroplakia, and submucous fibrosis are fairly common. But because of their potential to cause malignancy, the others are very important too.
Thank you, sir. That was indeed very helpful. Now, having understood the anatomy, incidence, and predisposing factors, let us now move on to the clinical features. Sir, could you please tell us how a patient with carcinoma tongue will present?
Definitely. But before we go into that, the students must remember that many of the symptoms we are about to discuss would be common to other oral cancers as well. When a patient comes to us with a non-healing ulcer, your ears need to perk up. The tongue is a very mobile organ, so it requires rich blood supply, and a good supply indeed means the small injuries heal very well, like the ones caused by accidentally biting on your tongue, which heal quite rapidly. So a non-healing ulcer is bad news, and this is where careful history taking is very important. So when did you first notice that ulcer is perhaps the most important question to ask. Now many of us have had ulcers. Either we bit our tongue while trying to eat too quickly, or we've slept too late due to the exams, or some of you might have even injured your tongue when your passions go out of control. But all these ulcers heal on their own. So when a patient says that their ulcer isn't healing, it surely means that something is serious. Worse still, if they complain of pain. Yes, pain is an ominous symptom. In the early stages, malignant ulcers are usually painless. It is when they have grown significantly and they affect the surrounding tissues that a patient will complain of pain. So a patient presenting with a painful ulcer usually means a bad prognosis. Now patients with malignant lesions will also have dysarthria, or which is known as difficulty in moving their tongue. This will accompanied by the excessive salivation. Now here's another little trick about history taking that I'll tell you from my experience. If you have a case with a non-healing ulcer on the tongue, ask the receptionist whether the patient was salivating a lot while he was waiting in the waiting room. Dysarthria and ankyloglossia due to the malignant ulcer make it very difficult to close the mouth completely, causing salivary secretions to dribble out of the mouth. In addition, irritation of the facial nerve that supplies to the taste buds causes excessive salivation. Another symptom could be the bleeding, which is caused by trauma to the ulcer. Now this bleeding, which is caused by trauma to the ulcer, a malignant ulcer is also liable to bleed on palpation. Now another presentation could be the fetor. This could be either due to the poor oral hygiene caused by a difficulty in opening the mouth, or due to actual tissue necrosis at the site of the ulcer. Sometimes the ulcer itself might be quite small and the patient may miss it, but due to the rich lymphatic drainage of the tongue, the patient might come to you with enlarged neck nodes. In very rare cases, the presentation may be in the form of an earache. This is why I say that a good doctor also needs to be a good detective and always alert for clues and atypical presentations. Can you imagine how gratifying it would be if you catch a malignancy at an early stage because of a thorough clinical examination?
Yes, indeed, I do, sir.
Now, before we move on to the next topic, let us take a quick look at the differential diagnosis of tongue ulcers, because not all of them are CA tongue. You should also consider the following points. the aphthous or the dyspeptic ulcer, the dental ulcer, the syphilitic ulcer, the tuberculous ulcer, the post-pertussis ulcer, and the chronic non-specific ulcer. Now, this seems a bit difficult to remember, right? So, I'll just tell you a simple mnemonic how to remember this. A, D, S, T, P, C, right? So, what is ADSTPC? A doctor should take proper care, right? So, if you remember this mnemonic, it's pretty simple to remember this. That is aphthous ulcer, dental ulcer, syphilitic ulcer, tuberculous ulcer, post-pertussis ulcer, and chronic non-specific ulcer. On that note, let us discuss the clinical examination. A meticulous palpation of the ulcer is very important because the ulcer itself is only the tip of the iceberg. The tumor is invariably much larger than what is visible to the eye. So, a careful palpation to assess the extent of the induration should be done. Another important thing to remember is that the tongue should never be pulled out of the mouth for palpation. What happens if you pull out is it becomes taut, and if it is difficult to identify the induration. I would like to give you another practical tip at this point. When you are palpating an ulcer, beware that these ulcers can be painful and the patient might just clamp down on your finger because of it. And this simple precaution will make sure that you have your index finger intact and not bitten by the patient. Now, malignant ulcers often bleed on touch.
Okay, sir.
A clinical examination must also include palpation of the posterior thirds of the tongue. The ulcers can be of various types. These include the fungating or the warty types, ulcerating or excavating types, those resembling a fissure, the nodular types, or when the whole tongue is like a frozen mass. We see two images on the screen. There is an ulcer on the lateral border of the tongue and the other one on the ventral surface of the tongue. What we see over here is there is an ulcer on the lateral surface of the tongue which is showing an ulcerative kind of a growth. The other one what we see is a fungating mass. There is a warty overgrowth on the ventral surface of the tongue. In a thorough examination, you should also look for dysphagia. Another important examination is that of the neck nodes. As I have already mentioned, involvement of the neck nodes is a quite common sign in the CA tongue. So, a thorough examination of the neck for enlarged nodes is very important. Just so that you remember this very well, let us look at a short video of a typical case presentation.
Hello. Today we are discussing a case of cancer of tongue. This 73-year-old gentleman presented with a ulcer on his left side of tongue. He had occasional bleeding in the morning. He also had some amount of pain while eating. This gentleman also had history of chronic tobacco chewing for last 40 years. He also had history of occasional alcohol intake. He has a tongue lesion on his left side of his tongue. You can see a ulcerated lesion with the edges uprolled, very typical of a malignant ulcer. Tongue bahar gaya. Yeah, now you can see it is on the lateral aspect, abutting his teeth, and otherwise his rest of the tongue is okay. His quality of his teeth is also not good. They are sharp, they eroded, and a lot of teeth have cavities also in it. The tongue examination is done when it is inside the mouth, because then tongue is lax and you can actually know the induration on the tongue of the tumor. When we do a tongue examination, we ask the patient to put out tongue, and tongue, if जीभ बाहेर काढा, जीभ इकडे लावा, जीभ तिकडे लावा. See, there is a restriction of movement on tongue on the left side. That means that इकडे लावा. See, there is a restriction. So tongue lesion is quite big, and I can feel that lesion. It is going up to the midline. But yes, this is what is the lesion. On his clinical examination, the tongue on left lateral side had a large ulcer of 3 by 2 centimeter. The ulcer was big, there was a bossulated feeling, the ulcer had everted edges and ulcerated base in the center. On palpation, the ulcer was coming up to the center of the tongue but not crossing midline. It was not extending onto the base of tongue. It was anteriorly coming close to the tip of tongue. This patient on clinical examination of neck had no enlarged neck nodes. The examination of neck is done by, from the anterior aspect, you see the submandibular nodes, you see the submental nodes and the level 2 nodes into the posterior triangle of neck. See the level 3 node. To see the level 5 nodes and the supraclavicular nodes, you have to go behind, and you can palpate these nodes from the posterior aspect. You can also palpate the upper posterior triangle neck nodes, which are called as level 2 nodes, from the behind. Again, you can check. He has no nodal involvement which can be seen. He was advised biopsy and a MRI scan of his tongue and neck. Before biopsy, we had to check in a 70-year-old gentleman or 73-year-old gentleman that he is on any antiplatelet agents like clopidogrel or ecosprin. He was on both these agents. Both these agents were stopped. During this time, he underwent MRI scan of his tongue. This is a MRI of tongue. The MRI, which is magnetic resonance of imaging of tongue, is generally done in oral cancer to determine the extent of disease. The MRI and CT scan, both these investigations are complementary to each other. In MRI tongue or MRI of hidden neck in cancer, the soft tissue abnormalities and soft tissue spread can be clearly defined with the neck spaces and the tongue involvement into the deeper structures. Here you can see this is a multiple images of MRI tongue. You can take this image where you can see the mandible, where you can see the multiple teeth. This is a section, axial section of MRI, and you can see that this is a base tongue, which the valvulae just there, and this is a pharynx, which is a blackish dot there. You can see this is a contrast enhanced image of the tongue where the contrast is accumulating over the lateral part of tongue with the shaggy margins, and this is a growth which is actually coming just close to the midline but not crossing midline. You have to also note that this growth is not encroaching into the base tongue. That would have made it inoperable. This is also not actually involving mandible, but that can be better seen in the CT scan, where the mandible bony images will show that the bone is free from disease. CT scan in head and neck cancer is generally done to see if there is bony involvement of mandible or maxilla. In this standard CT scan of head and neck with the bony window, what you can see is mainly the bone getting highlighted, because this is a bony window in a CT scan. You can see that the mandibular bone is not eroded anywhere and shows completely normal structure, bony structure of the mandible. You can also see a pharynx, which is very clearly seen. You can see vertebrae, but what is the point of interest is mainly about the mandible, because it is a cancer of tongue case. The lesion was seen to be involving lateral side of tongue, not crossing midline. There was one lymph node at the level 2 which was enlarged but not overtly metastatic. We took his biopsy after 3 days, and that biopsy revealed a moderately differentiated squamous cell carcinoma. The decision to go ahead with surgery after histopathological diagnosis of squamous cell carcinoma was done. In this gentleman also FDG PET scan was done. FDG is an isotope labeled sugar. When it is injected and whole body scan is done, the areas where the sugar intake is high are highlighted. You can see in this whole body PET scan image, the brain, which requires a lot of sugar, is enhanced. Liver also requires a lot of sugar, not as much as brain. It is also a little bit enhanced. The same sugar is excreted from the kidneys. So you can see there is highlighted areas in the kidneys, and the dye is into the bladder. But you can see there is an abnormal uptake onto the hidden neck area. This is the lateral side of tongue where the lesion is enhancing, showing that there is a possibility of neoplastic activity.
Wasn't that an informative video? Now let us look at the investigations once again. The most important investigation is a biopsy. Now there are two main types of biopsies, the incisional biopsy and the excisional biopsy. What you see here is an ulcer developing on the lateral border of the tongue. Now incisional biopsy is when you incise a small piece from the periphery of the ulcer for histopathological analysis. Always take a section from the periphery of the ulcer so that you can see the mitotic activity that is the representative of carcinomas. So this is how we take an incisional biopsy, that is from the periphery, representing both the physiologic as well as the pathological parts, so that the pathologist can compare both the aspects and come to a conclusion. Another type of biopsy is an excisional biopsy. Here what we do is excise the entire ulcer and send it to the lab. Now let us look at the 3D animation for the same. So we start by marking out an area that is at least 1 centimeter wider than the visible ulcer. This way, we make sure that we don't miss out any stray malignant cells. Then use a laser to cut out the lesion completely. And once the lesion has been excised, what you can see here is that we are also using the laser on the base of the ulcer. This again is used to make sure that we don't miss out on any stray malignant cells. And now since the lesion has been excised, you can simply close it using standard sutures and we are done. So the next most important investigation is that of the neck nodes. So if there are palpable neck nodes, a fine needle aspiration cytology, which is known as the FNAC, is done to confirm if there are any metastatic deposits in the lymph nodes. Apart from these invasive investigations, a CT scan, MRI or a PET scan is also recommended. This is very useful to confirm whether neck nodes are involved even if they are not palpable. Another advantage of a CT or an MRI is to define the extent of the primary tumor. If the malignancy has crossed the midline of the tongue, a radical surgery is required, so it is important to understand the size and the extent of the tumor. Apart from these, standard blood tests are also advised to assess the patient's fitness before surgery. This completes our investigation, and just for recap, let's see it again. We do a biopsy, then an FNAC, a CT, MRI or a PET scan, and lastly, and most importantly, the blood test. Once you have confirmed the diagnosis of malignancy, the next important step is to determine the staging. The TNM classification is a worldwide standard not only to understand the extent but also to determine the treatment and prognosis. Let us look at it in some detail. The TNM staging system is a standard way for doctors to describe and summarize how far a patient's cancer has spread. The most common system used to describe the extent of oral cavity and oropharyngeal cancers is the TNM system of the American Joint Committee on Cancer, which is known as the AJCC. The TNM system for staging describes 3 key pieces of information. Now T, as you would be aware of, indicates the size of the primary tumor and which, if any, tissues of the oral cavity or the oropharynx it has spread to. The N describes the extent or spread of the regional lymph nodes, and M indicates whether the cancer has metastatized to other distant organs of the body. The most common site for spread is to the lungs, and the next most common sites are the liver and the bones. Based on this, the tumors are classified as follows.
TX. The primary tumor cannot be assessed. Information not known. T0. No evidence of primary tumor. TIS. Carcinoma in situ. This means the cancer is still within the epithelium and has not yet grown into deeper layers. T1. Tumor is 2 centimeters across or smaller. T2. Tumor is larger than 2 centimeters across but smaller than 4 centimeters. T3. Tumor is larger than 4 centimeters across. T4. A. Tumor is growing into nearby structures. This is known as moderately advanced local disease. T4B. The tumor has grown through nearby structures and into deeper areas or tissues. This is known as very advanced local disease. N categories. NX. Nearby lymph nodes cannot be assessed. Information not known. N0. The cancer has not spread to nearby lymph nodes. N1. The cancer has spread to one lymph node on the same side of the head or neck as the primary tumor. This lymph node is no more than 3 centimeters across. N2 includes 3 subgroups. N2A. The cancer has spread to one lymph node on the same side as the primary tumor. The lymph node is larger than 3 centimeters across but no larger than 6 centimeters. N2B. The cancer has spread to 2 or more lymph nodes on the same side as the primary tumor, but none are larger than 6 centimeters across. N2C. The cancer has spread to 1 or more lymph nodes on both sides of the neck or on the side opposite the primary tumor, but none are larger than 6 centimeters across. N3. The cancer has spread to a lymph node that is larger than 6 centimeters across. N categories. N0. No distant spread. N1. The cancer has spread to distant sites outside the head and neck region.
Now that all the investigations are complete and the staging has been established, let us move on to the treatment. Sir, could you describe this, please?
Definitely. You should remember that for all the tumors up to the T3 level, the best course of action is to do an excisional glossectomy. If the malignancy has progressed to the T4 stage, then the palliative treatment like chemo or radiotherapy is suggested. Let us take an example of a T1 tumor and discuss surgical intervention. We have a 3D recording for such a surgery.
Could all the students please wear their 3D glasses to view the surgery? The TV needs to be switched to 3D mode. Are you ready?
This is the case of carcinoma of the tongue. Technically it can be called as T1 right lateral border of the tongue cancer. This patient does not have any neck nodes, but what the patient has got, if you can see where my light is shining, has adjoining areas of leukoplakia. What I am now showing is this is the area of the cancer, but this is a potentially cancerous area, this one. So I need to remove with a little margin, right from there, onto there, up there, and then back again like this. I am easy with this area because this is not cancer, whereas this is malignant. So I need to go like this. Now the power I am using is a continuous mode carbon dioxide laser. There are certain rules when you use laser. We have to protect the patient and the anesthetic gases. So we have a tube which is going on the other side, which is well protected. The patient eyes are well protected, and everybody in the OT is also covered and protected with the laser hit in case it does accidentally fly over. Now first thing I will do will be to mark out the extent of my excision, which is somewhere here. So this is the limit. This is the limit. But I need to go a little bit beyond to make sure that I have removed all the cancer. So I go about 1 centimeter behind, which is there, and make another mark here. Similarly, this is the area of the cancer. I will go a little bit away from it to mark an area there. Similarly, over here, you see the anteriormost tip, and I go and join these lines over, so I am abundantly clear that I have crossed the cancer all the way. And the lower edge here, this is the limit, and I cover this area up to there, and same over here, I go right out and join these two. And there, I go right out, and then I join these two to make sure that I removed all the cancerous area. So this is how I marked my cuts. Now, there's a little ooze here. This laser doesn't stop the bleeding. Can you take this? If the bleeding is more than 5 millimeter size vessel, in which case I need to cauterize that with a conventional cautery devices. Yeah. Now, once I have marked out my incisions, my next design of surgery is to remove all this lesion by joining these lines and joining that line to that line, and then I take a little small forceps Now this looks extremely easy. Believe me, it isn't so easy. I'm making sure that I'm well away from the cancerous growth, and if I get a meat into some small bleeding, I stop that bleeding by using a bipolar diathermy device. These are potentially cancerous areas and we have removed them. This was our earlier mark. We have gone beyond that mark, so we are well clear. This was our earlier mark. We have gone beyond there. What we do next is called a sterilization of the area. And the way we achieve that, this laser goes through by about a millimeter or a cell depth. So what I'll do now is just hitting and making sure that I remove a cell layer depth extra than what I saw with my naked eyes. So that ensures that we have done the surgery little bit more than what the eyes meet. So that's the way you treat cancer. And the reason why it bleeds so is the tongue is one of the most vascular organs in the body. And now we close the defect primarily. In earlier days, when lasers were not in practice, this was removed probably by either a straightforward cold surgical instrument like a knife, or maybe a diathermy, which is a extremely heat producing instrument. And the lateral thermal damage of the diathermy cautery is almost 1.5 centimeter. So you imagine that the patient will be subjected to a tissue damage about 1.5 centimeters beyond your eyes can see. And that is not desirable. Whereas the laser only heats up about 2 cell deep. That is less than 0.2 millimeters. That means there is negligible 10 microns. So there is very little lateral thermal damage. This will heal within a week. And as I said, the patient goes home tomorrow morning. He calls me up, maybe 3-4 days time when the histopath report is final. And then there is a happy review after a month. There are not much restriction on the patient. Patient eats normally, drinks normally, and most of my patients are coming 300-400 kilometers away. So it's very fast, economical, and time-effective treatment for these patients with very small, limited lesion of the tongue, like this T1 cancer of the tongue.
That was very good, wasn't it? Now, you must remember that depending on the size of the tumor, there are various types of glossectomies that can be performed. These are the wide local excision, the small wedge excision, the slightly larger wedge, then a much bigger hemiglossectomy, and finally a subtotal glossectomy. Now, apart from these, there are also some other surgeries that may need to be performed for the larger tumors for excision or for the access, such as the lip split incisions, the lateral mandibulectomy, or even a pull-through glossectomy. The challenging aspect here becomes the neck dissection. In brief, if we have an N0 neck, the surgeon may opt for a supraomohyoid neck dissection. Site selection, however, here is also a crucial part, especially for the midline nodes. For clinically positive nodes, however, one must consider frozen section biopsy, and later post-op radiotherapy is a must. One trivial aspect, though rare, is skip node metastasis, which should be addressed to. Advanced centers, if equipped, may also use the sentinel node biopsy. Now, excisions that have removed more than 1/3 of the tongue would also need post-operative reconstructive surgery with techniques like the radial forearm flap or the pectoralis major myocutaneous flap. Depending on the extent of the malignancy, additional radiotherapy and chemotherapy may also be required. If the malignancy has progressed to a T4 stage, then the treatment would be like a chemo or radiotherapy. Depending on the extent of the malignancy, additional radiotherapy and chemotherapy may also be required. If the malignancy has progressed to a T4 stage, then treatment like chemo or radiotherapy is only palliative in nature. Radiotherapy can be teletherapy or brachytherapy. Chemotherapy has good response, but it generally does not translate into an improvement in chances of survival. A single agent or a combination of drugs can be used. For palliation of pain, sometimes chemo using drugs like platinum compounds or 5-fluorouracil can be used.
Thank you, sir. Now we will move on to the last topic of our lecture, and that is prognosis. All malignancies are associated with a poor prognosis, but the outlook is not that bleak in the case of carcinoma tongue. Am I right, sir?
Yes, you are right, Vinita. With the advancement in treatment, the morbidity and mortality has significantly reduced. Patients with even a T3 lesion could expect to lead a perfectly normal life. A lot of credit for this goes to the effective reconstructive surgery. Patients can actually expect to eat, talk, drink and even sing like they used to do it earlier. The problem arises when the tumor has spread to the neck. Neck node metastasis usually spells poor prognosis, and survival rates drop from 60% in the case that doesn't have nodal involvement to 35 to 40% in cases where there is nodal involvement. There is a 5-year survival rate usually which is reported. Distant metastases usually have a poor prognosis, just like with any other malignancy. Now I'd like to move on to the prevention of tongue cancer. This is one cancer that can be avoided. We understand the etiology quite well, so prevention is really in our hands. The most important aspect here is awareness. Tobacco in all forms has to be strictly avoided. Dentists are also playing a very important role in the prevention. The sharp teeth and ill-fitting dentures as well as the pre-malignant conditions will most likely be diagnosed in a dental surgeon's clinic. With such measures, I am an optimistic person that India can lose the dubious distinction of being the world's capital of CA tongue.
So this was our lecture on carcinoma tongue. Thank you, sir, for conducting a wonderfully informative session for us. Now that we have learned the various aspects of CA tongue, sir, could you also tell us what kind of questions a student could expect in the examination?
Sure. In the exam, the typical long answer question is, describe the etiology, clinical features and treatment of CA tongue. Your answer must contain all the points we have discussed today in the 3 sections of the lecture. A typical short answer question should be, enumerate and describe pre-malignant conditions of CA tongue. We have covered this in section 6 of our lecture. Very quickly, these are leukoplegia, erythroplakia, chronic hyperplastic candidiasis, oral submucous fibrosis, syphilitic glossitis, sideropenic dysphagia, oral lichen planus, discoid lupus erythematosus, and disc keratosis congenita. Now let us assess how much we have understood in today's lecture. I am going to present a couple of MCQs, that is multiple choice questions. Here is the first one. What is the single most important etiological factor causing CA tongue? A. Is it spicy food? B. The sharp teeth? C. Tobacco? Or D. That is poor oral hygiene?
Sir, I think the correct answer is C. Tobacco.
Oh, you're absolutely right on that, Vinita. So now, here is the second multiple choice question. A tumor on the right lateral aspect of the tongue, that is 2.5 centimeters across, hasn't crossed the midline, has a right neck node enlargement of 4 centimeters, but no distant metastasis. It should be classified as A. T2N1M0, B. T1N2M0, C. T2N2AM0, or D, that is T1N1M1.
The correct answer should be C.
Yes, again you are absolutely right, Vinita. Let us now begin our interactive session with Dr. Kapre. Please use your raise your hands option to ask your questions.
So today, we learnt about the various aspects of CA tongue, including the anatomy of the tongue, epidemiology of CA tongue, its etiology, some pre-malignant conditions, clinical features of CA tongue, along with its examination, investigations, staging, treatment, prognosis, and prevention of CA tongue. I hope this lecture was a productive one. Don't forget to download notes for this lecture using your smartphone app. If you have any difficulty in doing so, I'm sure your teacher will be able to help you out. Thank you.